I think, are we good to go?
Very good morning, everyone. Welcome again to ISC Masterclass. And this is 26th in the series of Masterclass. And this is second in the series of GI cancer Masterclasses. Last week, we had a panel discussion on gastrointestinal lymphoma, which was moderated by Dr. K.M. Mohandas. And I think that the whole masterclass went very well. Very important point we discussed, and some of the practice points were highlighted. All we know that carcinoma gallbladder is a very important disease for gastroenterologists, and we get a lot many patients with carcinoma gallbladder coming to gastroenterologists, surgeons, and to radiologists and oncologists. So therefore, we thought we do a masterclass on how do you manage a patient who have a carcinoma gallbladder. There are a number of issues, and for that we have designed a panel discussion to discuss the important issues which are clinically relevant in patients with a carcinoma gallbladder. For that, we have a panel today, which is very esteemed. The panel will be moderated by this panel will be moderated by Dr. Vivek Saraswat. Dr. Vivek Saraswat is a professor of gastroenterology, and he's head of gastroenterology at SGPJ Lucknow, and he is also president of Indian Society of Gastroenterology. On the panel, we have Dr. Anil Agrawal. Dr. Anil Agrawal is again professor and head of GI surgery at GB Pant Hospital, and he's also director of GB Pant Hospital. He has a lot of interest in carcinoma gallbladder. He published a number of papers, and he has a lot of interest in surgery of carcinoma gallbladder. So he'll discuss the surgical aspects of treating carcinoma gallbladder. We have Dr. Atul Sharma. Atul Sharma is a professor of medical oncology at All India Institute of Medical Sciences in New Delhi. Again, he has a lot of interest in carcinoma gallbladder management. We have a third panelist, Dr. S.S. Bachel. I think very famous face to all of us. One of the first top-class interventional radiologists who established interventional radiologists in our country. He is chairman of Department of Interventional Radiology at Medanta Medicity, and had a number of publications to his credit. We have one other very dear colleague as a panelist, Dr. Praveer Rai. He's a professor of gastroenterology at SGPJ Lucknow, and he will dwell upon the many aspects of palliation in carcinoma gallbladder. With this team panel, I think we are very proud today that our panel has a lot of experience in discussing these issues which are relevant. And I hand over to Dr. Saraswat to take on from here and start the panel discussion. Meanwhile, you have any question, you can put your question in the chat box. We'll come back with your questions. And all those joining from neighboring countries, welcome to everyone. Dr. Saraswat, please.
Thank you very much, Dr. Govind. A very good morning to all of you who have tuned in, our viewers and participants, as well as to the panelists. As Govind has just explained to you, gallbladder cancer is the commonest cause of malignant extrahepatic biliary obstruction, particularly in the northern part of our subcontinent, in fact, in the entire Indo-Gangetic belt. As we all know, there is a lot of factors that are quite distinctive about gallbladder cancer, not the least of which is its association with gallstones, the female gender preponderance, its predisposition or its predilection for the Indo-Gangetic belt that I just spoke about, so one of the most heavily populated parts of the globe, and also the dismal outcome in this condition, which has remained unchanged over the last half century or so. Today we are not really going to be talking about all these aspects, which of course need a lot of attention, the etiopathogenesis as well. We are basically intending to concentrate on the management of gallbladder cancer. As you all know, barely about 5 to 10% of gallbladder cancers are generally resectable. The large majority, the vast majority, in fact, 90 to 95% need some form of palliation once symptomatic disease supervenes. And for this, we have in the panel discussion format, assembled this an extremely eminent and highly experienced panel. As you know, Northern India being the place where this disease is found, centers like GB Pant Hospital, the All India Institute of Medical Sciences, SGPGI, have a very large experience, and we have faculty members from there who will be talking about their respective areas of palliation. The way that we propose to go about is that I have devised a set of questions which we will be posing to each panelist, and they will then be sharing the screen with their slides to answer some of these questions. So now, to set the ball rolling, my first set of questions will be addressed to Professor Anil Agarwal, who has vast experience in the surgical management of gallbladder cancer. And in the next few minutes, 8 to 10 minutes, I'll request him to tell us which patient of gallbladder cancer is resectable. Is a cure possible in gallbladder cancer? If so, how often does that happen? Which patient is borderline resectable? That means with some extra interventions, an apparently unresectable patient may be rendered resectable. How does he choose patients for resection? What is the workup or his approach to patients to try to triage them into ones who are resectable and who are unresectable? And finally, the results he has achieved and the literature reports about this condition. So with these few questions, I request Dr. Anil Agarwal to share his screen and please begin the presentation.
Good morning and thank you very much, Dr. Saraswat, Dr. Govind, and am I audible?
Yes, you are.
Yeah, okay.
Please go ahead.
So thank you very much for the opportunity, and Dr. Govind. My brief is to take you through the surgical management in brief, and I think it will be primarily focusing on to take most of our physician colleagues from that overall the nihilistic approach which is there for gallbladder cancer to take you to realize that realism and now that reasonable results are possible in this disease as well. So I think this is the way the gallbladder cancer can present either after cholecystectomy and it is realized that on histology it is, which is incidental gallbladder cancer, or gallbladder cancer limited to gallbladder rather than TNM. I'm just talking about from the practical management approach, or when it is infiltrating into the adjacent viscera, and some of which will come into the borderline resectable category as Dr. Saraswat talked about, and we'll deal with it later, and metastatic gallbladder cancer, which we are, the workup is planned to rule out that there is any metastatic before we take up for surgery. So I think it is important that the disease aspect and the patient selection is done, and the workup which all of you know about, the CT or MR, and MR is preferred in when it is a biliary obstruction, and identifying patient who would or would not benefit from surgery, which would primarily mean that one, detect metastatic disease. And as the world literature talks about that when there is an intra-aortocaval lymph node or the 16B1 lymph nodes are positive, then it doesn't have very good results. And so I think earlier we used to do an intraoperative frozen section analysis, but we have moved on a little from that to talk about endoscopic ultrasound guided in patients in which CT or ultrasound guided FNA is not possible. And this we started long ago with Dr. Pramod Garg at All India Institute, because at that time, there was no literature suggesting that EUS would help in such cases. And loco-regionally advanced disease, which we talked about, borderline resectable, or depending on your philosophy that how far you will go to resect, some of these are also resectable. And despite all imaging, including PET scans, small surface liver metastasis or peritoneal deposits are still missed. And so it is important that rather than doing a laparotomy, which will be futile, to go for a staging laparoscopy. And we analyzed our experience and published it. And at that time, assessed for operability was 773, and out of which primary gallbladder cancer 409 patients. And this is the paper we published. And we realized that even though the yield was high in locally advanced gallbladder cancer, however, almost an equal percentage of patients you could avoid a non-therapeutic laparotomy. And we realized that some of the sites were missed in a single port laparoscopy, so moved on to doing a 2-port laparoscopy, and also subsequently added an intra-aortocaval lymph node biopsy, because this part which we were earlier doing by open method, now you realize that you can do that and avoid a full-fledged laparotomy in such cases. So I think, let me first take you through when it is a patient which is resectable. I think the issue that Dr. Saraswat talked about, curable, I don't know whether it is curable is a term which can be, though some patients of ours who have been more than 10 years or 12 years and who have died of natural disease, like one of the patients which was operated 69, surviving 12 years, and another patient, 82-year-old, who survived about 9-10 years. Now, you could say that they were virtually cured, but I think we can't really say that there is a curative surgery. I think more of that you aim for removing and doing an R0 resection. So I think if it is not advanced to adjacent viscera, what you need to do as part of standard radical cholecystectomy is liver resection and lymph node resection. And liver resection, as you can see, this is the segment 4B5 resection. You could do a wedge also, which yields equal results. And lymphadenectomy, you take all these groups of lymph nodes that you've talked about along the hepatoduodenal, along the hepatic artery, and behind the pancreas. And behind the pancreas was some doubt because in AJCC 7, they're included together with celiac. But if you look at the Japanese literature, it makes sense in resecting, and they have a lot of long-term survivors in this. And so similarly, even in incidental gallbladder cancer, I'm just touching upon that beyond T1B with positive cystic duct margin or cystic lymph node positive, you do a completion radical cholecystectomy, which is similar to what we would do for a primary gallbladder cancer like this, as you've talked about. In addition, however, we do a port site excision of all ports. I'm not going into the debate and discussion about, but this is a philosophy we have been following because in our country, most of the gallbladders are not removed in a bag. So, I mean, just to touch upon that, we have moved on. And when we were talking about nihilism, and in fact, I want to highlight this because now the world literature has shown equivalent results for minimal invasive approach also, because a lot of times you hear that, oh, minimal invasive, you can't do as good a clearance. So I think that is a thing which needs to kind of, one needs to accept that minimal invasive approach with all the attendant benefits is an approach to follow even for gallbladder cancer now. And there were concerns, and most of important of which was a port site metastasis, which as the techniques were refined and people realized with the Professor Hahn's paper in 2010 that port site metastasis was more a myth than a reality, and it was more a reflective of improper technique. So I think with the proper technique, it was not really a hindrance. And I think this is one of the patients of ours in which we have done a laparoscopic segment 4B5 resection and lymph node. Again, you do the same lymphadenectomy as you do in an open approach, and this is what is left behind with all the structures bared with the lymph nodes having been removed from them. And this was a consensus statement, which we were also part of it. In 2016, Professor Hahn had held a consensus meeting in Korea. And now, in fact, there are a lot of papers in the last 2 years with 70, 80 patients and one cumulative series which has come of 235 patients. And we are in the process of publishing our experience of 170 plus cases. So I think it has moved on to include laparoscopic approach as a reasonable approach. And with the, apart from equivalent oncological results, you have a very good cosmetic result. And this is one of the patients, and especially so in these morbidly obese patients like this one, which we operated about 1.5 months ago. And it was a short-statured man. And even though it was a COVID times, about 2 months ago, I think, and we were wondering, but we thought that it would not be right to give him a big incision. So we went ahead laparoscopic. And so coming to the adjacent viscera involvement, it could be in form of duodenum, colon, or pancreas, or with biliary obstruction and vascular involvement. So, I mean, this is a paper that we also published, that we can do a distal gastrectomy and D1 or a proximal duodenectomy. And we published this paper, and we realized that there were prolongation of survival, and you could avoid doing a HPD in these patients where it was a limited duodenal involvement. And I think we analyzed this paper for tropical gastroenterology, in which we analyzed that because our approach is to resect 2 or more adjacent organ also, but we realized that if we had not done that, our resectability would have been 37.6%. However, in this series, because we resected those, it was 57.5%. And this is, we realized that median survival was significantly less, of course, when the extrahepatic adjacent organ was involved, but it was 33 versus 48 months. However, there was no significant difference in the median survival of node-negative GBC patients between 2 groups. So it was not necessary that when the fundic or a body tumor is involved in the duodenum or the colon, that will necessarily lead to lymph node positivity. And among node positive patients, median survival was significantly less in patients with 2 or more adjacent organ involvement. And so this is just cumulative experience from the Japanese data, a little oldish paper, but it is highlighting even at that time, because we have been following and the world is moving toward the Japanese approach. And you realize that even in node positive, because even if you talked about 5-year survival in PN3, and in fact T4, 14.1%, but mostly you people talk about very poor results. So I think it varies from 90%, 85.9% to about 14%. And gallbladder cancer with jaundice, which Dr. Bajal will be covering more in detail, but preoperative biliary drainage, endoscopic or percutaneous, and preoperative portal vein embolization. But what we have been following is that we do a parenchyma preserving resection, and not all of these patients need an extended right hepatectomy. And this is a patient which was 12-year survival in which we did an extended right hepatectomy, but now we modified an approach to preserve that segment 4A. And in fact, a lot of times that you get that extra tissue and the risk of liver failure reduces. And so this is a paper in 2007 we published that it was titled that is not sine qua non of inoperability. And this I want to highlight because a lot of time when the physician sees the patients and thinks that if it is jaundice, then probably it is unresectable. Now we have more than 150 patients which we have resected. And the last nail in the coffin was by this Professor Nishio, that is Nagino group, in which they had a much larger series than ours, which was published in 2007 of 73 patients and with bile duct invasion with reasonably good results. So I think just in the last segment, I would talk about that even the laparoscopic approach, now you can go on to adjacent viscera resection. And we have, we contributed to that installed 2 study, which was from Japan. And we contributed about 9 patients in that series out of the 11 patients in which the bile duct excision was done. And we have now 11 patients in which we have gone ahead and done beyond a standard radical cholecystectomy by laparoscopic approach. These are the details of that. And in some patients, single organ, double organ, and 3 organs have been done. So thank you very much for your attention. I hope I have stuck to time. I had to rush through, but Dr. Saraswat, I hope I have not exceeded time.
Yes, you have done a great job, covered a lot of ground. If you could just stop sharing your screen,
I'll just
we will then move to the next segment. The question answers and the things that have already started coming into the chat box, we'll take at the end of the rounds of presentation. And we now move to the next set of questions in this series of discussions. What we had discussed just now is which patient is operable and what is the extent of resection, which Dr. Anil Agarwal has covered extensively. Now, I think there are patients who would come in the borderline category who may benefit from approaches to maximize resectability, such as the use of neoadjuvant chemotherapy and such as embolizing the portal vein to enlarge the liver and thus have a good functional liver remnant. For both these approaches, we will have presentations, and now I'll request to answer these questions about resectability, Professor Atul Sharma. Atul Sharma is the Professor of Medical Oncology at the All India Institute of Medical Sciences, and he'll be talking to us about neoadjuvant chemotherapy of gallbladder cancer. Professor Atul, please.
All right. Thank you, Govind and Dr. Saraswat. So my job is to discuss about the neoadjuvant chemotherapy. So the problem with the gallbladder cancer, as Dr. Saraswat has highlighted, is majority of them will be unresectable. So as of now, the other problem with the gallbladder cancer is that unlike many solid tumors or the liquid tumors, this is not considered as a this thing, what would say, chemosensitive. Can we go to the next slide, please? Yeah, it's not considered a chemosensitive disease. So the lot of things are going on, but as of now, this is not considered the standard, and this is considered the experimental. So we probably a lot of people or group are working on this thing. So we designed our own study, and which we have completed basically. So there may be the question about whether you want to use the two-drug combination, gemcitabine platinum, which is considered active in gallbladder cancer, or we want to use the three-drug combination, which is using oxaliplatin, irinotecan, and 5-FU. The advantage with the three-drug combination is that in pancreatic cancer, a lot of protocol for the gallbladder cancer have been developed from the studies which were completed in the pancreatic cancer. So we designed similar study, and the advantage with this theoretical advantage with this particular combination is that it has the higher response. With the gemcitabine and platinum compound, the responses are in the tune of 20-25%. With this combination, people do expect that it may be in the tune of about 50%. So we have seen this protocol we run through in the department, and we have found that about 45. We can go to the next slide, please. So we can go to the next slide. So with the combination that we called it the modified FOLFIRINOX, this is a highly toxic protocol. So that's why we have chosen the patient who are either in the ECOG 0 or 1. So for the non-oncologist audience, basically the ECOG generally denotes the general well-being of the patient. So these are the toxic protocol, we consider them the good performance status will be able to tolerate this. So, but this is highly toxic. Grade 3 and 4 toxicity are in the tune of about 40%. The fortunate part is that we didn't lose a single patient, and we have seen the responses in the tune of 45%. And if you see, this is small segment which is going for the publication now. 2 of these unresectable. So what I'm saying is the unresectable, not the borderline resectable. So unresectable patients were made resectable. So probably now we want to explore this further in the borderline resectable patients. We can go to the next slide, and probably that is the last. So usually would also try to adjust to address the issue that the surgery is the best modality. Whenever there is a resectable tumor, should go for the surgery. Borderline resectable, we are starting a protocol. Other people are also starting, but as of now, this is not a standard. I would stop here.
Thank you very much, Dr. Atul, for telling us about that these newer combination of chemotherapy for neoadjuvant therapy in gallbladder cancer. Now, the other modality that has been explored for making a borderline patient resectable is a strategy of portal vein embolization. And I will invite Dr. S.S. Bajal to please take us through what are the steps of embolization and the technique, as well as expected results from and the considerations for before we undertake portal vein embolization. Professor Bajal, please.
Good morning, or it's actually afternoon. So before we get on to portal vein embolization, we've got to understand which are, and we realize that elderly age groups and patients in whom you need a much larger expansion of the volumes, patients who have a poor ICG clearance and a very high pre-intervention bilirubin, in the sense that if this liver is exposed to very high levels of cholestasis, it's been found that even after adequate biliary drainage, you do a portal vein embolization, you may not get such great results. But understanding this, we have to therefore optimally decompress the bile ducts and then get on with portal vein embolization and hope that we get hypertrophy. Next, please. So in non-cirrhotic patients, we can understand that in the first 2 weeks, you would get the best results of the embolization of the future liver, which is going to get resected, and your FLR would expand, which would then go down at the rate and come down to half its speed of hypertrophy to 11 at 4 weeks, and by nearly 32 days, that's about all you can expect. We know that in cirrhotics and patients who are diabetic, it's much, much slower, and hence, if you look at 4 weeks in those patients, you really don't get too much. But it's understanding and accepting this, and then we move ahead. Next slide, please. There was some talk about what happens to the primary tumors after the portal vein embolization has been done, and so it was interesting to see data in which portal vein embolization was done in the HCC groups, and they did a TACE, and they realized that The necrosis induced by TACE somehow stimulates liver regeneration. There's no artery buffer response, obviously, because you knock the artery off, so you would get better results of PVE. And the arterial embolization knocks off the arterioportal shunts, which would again then improve your results of PVE. Next, please. And therefore, if you were to see that the FLR volumes were much higher when TACE plus PVE was done as compared to only PVE alone, and on the add-on advantage, you also got complete tumor necrosis much more in the TACE groups, which resulted in improved 5-year disease-free survival. Next, please. If portal vein embolization doesn't work, we've now realized that total venous deprivation is an option. And in fact, now there is discussion whether it should be sequential after 4 weeks of PVE or should it be simultaneous along with PVE, in which the main concept is that you've got to occlude the hepatic veins again of the ipsilateral side, the side that's going to get resected. But not only at the rostia, it's important to get tissue embolization on the outflow veins, and that means that you've got to go to the bed. And hence the embolic materials that are used for venous deprivation as well as for portal vein embolizations have traditionally always been particulate in nature. There's some experience now coming in with glue, and we've actually moved a lot also towards glue. Using 15% glue, you can really get deep into the venous channels and get good results. Next slide, please. And therefore, if you see the results of a combined complete deprivation, you get much better hypertrophy as compared to portal vein alone. Next, please. Complications of the entire strategy. There is this data of nearly 1,000 patients, and we are happy to see that there are no huge catastrophic complications, and the percentages of these complications ranging from liver abscesses to septic necrosis are numbers that can actually be counted on your fingers. So it makes for a very promising method to be used to get these patients onto the surgical table and try to get them to a resection. I think that completes my views on PVE.
Right. Okay. Thank you very much, Dr. Bejal. We have you've got an understanding of what it takes to embolize the liver, that is the tumorous side, so that the healthy liver hypertrophies and gives you a good functional liver remnant. And this will then improve the resectability rates as have been discussed. Now, if you have a resectable patient who is a candidate for surgery, and the problem we encounter is that these are people who are deeply jaundiced. So before proceeding either for surgery or for any of these other approaches, neoadjuvant therapy or portal vein embolization, a preoperative biliary drainage is required. And so for this, I have some questions for Dr. Anil Agarwal. If you could answer them, please. In which patient will you ask for a preoperative biliary drainage? And once you have done a preoperative biliary drainage, how long do you usually wait for the bilirubin to touch normal? And do you encounter any problems while waiting for taking the patient to the OT for resection? Anil, please.
Yeah, am I audible? Yeah.
Yes, Anil.
Yeah, we would do biliary drainage in patients who are either the duration is longish or it is more than 10 as a cutoff we want, and it will depend on what is the magnitude of resection. So any patient which is likely to need a extended right hepatectomy, we would want to do a preoperative biliary drainage, bring down the bilirubin. We try to aim for a normal or less than 3, but we would accept even at times less than 5, and depending on the patient condition, because during this period, the malignancy also seems to be progressing. So that is why you have to kind of a trade-off, because the best results would be that if you had a near normal, but because I think initial fall is quicker and subsequently the fall takes more time. So that is what we would do. And we would talk about endoscopic or PTBD. However, when the hilum is patent, most of the time endoscopic palliation is what works well. But even in those when there is a hilar separation, I think the endoscopist would try to drain one side, that is a future remnant liver, which remains. And I think if that doesn't work, then on the same day, probably it's better to go for a PTBD. so that you don't encounter that.
In your experience, while you are waiting for bilirubin to normalize and things to improve, have you faced problems like progression of the tumor to what
Yes.
operable becoming inoperable, and usually how long is this wait?
Yeah, usually it is 3 to 4 weeks wait, I think, because depending on what bilirubin level we started with and what kind of whether the hilar separation is there or not, and what is the method of drainage which has been done. Because if there's a hilum which is intact and you've done an endoscopic or a PTBD, it is much quicker fall. Whereas if it is a separation and you are palliating or you are only draining one side, then the fall is slower. And yes, we have encountered that the patients, the malignancy seems to progress. And in fact, long time ago, we also thought that once the bilirubin came down a certain level, can we start limited chemotherapy or take the help of chemotherapy? But we realized, or maybe between 5 to when it is normalizing, but we realized that they tend to make the patient sicker. And
Right.
we've abandoned that approach. And I think I was discussing with Professor Yuan Fong once about this, the disease seems to progress. He said that these are then kind of by natural selection, the patient which would not have been helped even if you had gone in early.
Right. Thank you, Anil. Dr. Praveer, I think I take your inputs regarding preoperative biliary drainage, endoscopic, plastic or metal stents, or at really you might have to opt for percutaneous. So what is your approach to endoscopic preoperative biliary drainage? You prefer plastic or metal stents depending on the duration, and which would be patients in whom you might consider metal stents, Dr. Praveer?
Yeah, I think one is about the endoscopic versus percutaneous. I think I'll be covering that. But about plastic and metal, the only reason to choose plastic is the cost, because metal stents definitely are expensive. So plastic stent, if the surgery is not delayed too much, then plastic stents, if we expect surgery to be done within a period of 4 to 6 weeks, we can choose to place plastic stent. Otherwise, the only constraint that is there with the metal stent is the cost.
Right. So if a neoadjuvant therapy were to be done, or if a person is planned for something like portal vein embolization, when the wait may be longer than 4 weeks, but that is one concern about patency, and the other is at the hilum, you may not be very comfortable placing metal stents.
Yeah, so for hilum, if metal stent is chosen, it has to be an uncovered stent. We can't place a covered stent in the hilum. And obviously the confluence is blocked. Then again, there are unilateral versus bilateral will be the issues. So pre-operative, if we think of placing a metal stent, I think the factor which prohibits it's the cost.
Can I make a comment?
I think we can move along and take at the end.
I think this is important. So can I make a comment? Because, the metal stent at the hilum. Yeah.
Please go ahead.
Yeah, because I think I would be wary of inner resectable tumor, even if you put in an uncovered stent, because those are the worst nightmare to operate. And I think apart from other things, even to get the resection margin. So I think my request to all endoscopists would be that it should be seen by a surgeon to say that it is unresectable. Then you can choose to put in a mesh metal stent. But otherwise, whether covered or uncovered, please in hilar block, do not put it, whether it is gallbladder cancer or a hilar cholangio. The worst experience we have had has been with such patients.
Yes, thank you. Yeah, that is understandable, because when you have a bare metal stent, getting it out is really tough. So now I think we come to the question of, once you have done a resection and the surgeon has done his job, as Dr. Anil has shown us, what is the place of adjuvant chemotherapy after resection? And I may ask Dr. Atul Sharma to come in and talk to us about adjuvant chemotherapy for gallbladder cancer. Dr. Atul?
Yeah. Thank you once again. So just like we were talking about the neoadjuvant chemotherapy, unfortunately, we do not have the standard protocol for the adjuvant chemotherapy. We have 2 or 3 recent publications published randomized phase 3 studies, which does suggest that there may be some improvement of the overall survival. But the problem with these 2 or 3 studies are that probably said they did not reach the statistical significance level. So what I would like to say that there is improvement, clinically meaningful improvement, but did not reach the statistical value of improvement. Can I have the next one? So these were the, I think, presented and published about 2 or 3 years ago and published last year. This is the known as the BILCAP study, European study, UK based, and they randomized after the surgery to either. Another problem I would like to highlight here for the audience is that all these Western studies, they have combined all the biliary tract malignancy in one basket. They have put the cholangiocarcinoma, extrahepatic, they have put the gallbladder cancer. And as the gastroenterologist, probably you understand that the biology of the tumor and the response to the treatment is different between the cholangio versus the gallbladder cancer. So anyway, having said that, this study tried to look whether there is a use of using capecitabine, which is an oral FU, compared to the observation alone after the surgery. Next one, please. And this study probably, they showed that as such, when you go for the intent to treat analysis, there is a significant, meaningful improvement by using capecitabine, but it did not reach the statistical significance value. However, I would like to highlight there were the 2 protocol amendment during the study, and when they did the per protocol analysis, it reached the statistical significance. And based on this study, there are a lot of people who are using capecitabine after the surgery. So this was the another publication which was we published. It was published last year and presented 2018. And this study probably also used they used the gemcitabine and oxaliplatin, and they were compared with the observation alone. And this study, when they saw that it did not reach statistical significance. Next slide, please. So there was no significance. However, if you see, we can skip this thing, so we can go to the next graph, please. Yeah. However, the problem was that unfortunate thing was that when they analyzed the gallbladder cancers separately, they found that the chemotherapy did really harm to these patients. We don't believe in this study, and that is the reason. Next one. Next one, please. So this is another study which probably results are awaited. Next one. Next. So now we also started a similar study in 2018. And so this study, we are trying to see whether chemotherapy versus chemoradiation is helpful or not. And this study is ongoing. Unfortunately, we have enrolled close to 100 patients, but because of the small and slow recruitment, we probably might be considering early closure or stoppage of this study. Thank you. So the gallbladder cancer adjuvant treatment is questionable, debatable as of now. We practice it, many other practice it. Thank you.
Thank you, Dr. Atul. So that is useful information for many of us who are not using it routinely. Now we come to the subset, which is about 90% or so of gallbladder cancer who are not resectable, who are symptomatic due to a variety of problems, most often related to biliary tract obstruction, but gastric outlet obstruction, pain, these can be some of the symptoms that are amenable to palliation. And now I will request Professor Praveen Rai to take us through the options available for patients with biliary tract obstruction who are in need of endoscopic palliation in gallbladder cancer. So I'll stop sharing my screen and I'll request Praveen to
Dineshi, Yes, Praveer.
Yes.
Can you share the screen and then?
Okay.
I think there's some network issue.
Am I audible there?
Yes, we can hear you, Praveer.
Yeah. So majority of the patients with carcinoma gallbladder have advanced incurable disease, and majority of these are not candidates for surgical resection. The median survival in these patients is around 2 to 4 months. Therefore, what we are intending in these patients is palliation. And 3 important symptoms which we intend to palliate are primarily jaundice, gastric outlet obstruction, and pain. Here I will be discussing about jaundice because of the paucity of time. So the goal of palliation is to provide symptomatic relief, improve nutrition, and improve the quality of life. So you can't palliate each and every patient. So patients who are primarily unresectable, inoperable disease, or the patients who have denied surgery are the ones who merit palliation, who have distressing symptoms of jaundice, vomiting, and pain. However, what we need to see that the palliation should be technically feasible. If we are doing it either endoscopically or percutaneous, the patient should have a suitable anatomy. We should see the type of the block the patient has. And in case we fail with a particular technique, the backup option, whether that is available or not, and the cost involved in the procedure. Because if we are talking of hilar blocks, then we need to place single stent or 2 stents, which adds upon the cost. Then another very important issue is the performance status of the patient. If we have an ECG score of, say, more than 2, sometimes these patients are difficult to undertake for an prolonged endoscopic procedure. And there are certain group of patients where you don't intend to palliate, when you have multiple metastases with a bad performance status, and when we have more than 4 to 5 systems to drain. So before resorting to biliary drainage, we need to do MRCP in each and every patient. This is primarily to look up the type of the block the patient has. You're all aware of the Bismuth classification, so we need to be sure whether it's type 1, 2, 3A, 3B, or the 4. And this will decide how many stents we need in case we are choosing to place multiple stents rather than a single stent, which sometimes is needed in patients with cholangitis. So this MRCP delineates the extent of the biliary obstruction. MRI along with that, or CT tells you about the lobar atrophy you have. We have talked about segmental portal vein embolization, and this is assessed primarily with the imaging that you do. So what is said, if you drain more than 50% of the liver volume, you have better drainage and a survival advantage. This is what is accepted. There is a subgroup of patients where you have failure of resolution of jaundice, and these may be where you have high baseline bilirubin level, where there is diffuse liver metastasis, and when an INR is more than 1.5. So I don't know whether you will be able to see the slides clearly, but what it shows, these are the different modalities of biliary drainage that you have. So these are endoscopic, which can either be an ERCP or EUS ERCP rendezvous or an EUS guided technique. Then once you choose a particular technique, you have an option of placing a plastic stent, you have an option of placing a metal stent. In an EUS guided procedure, you have the option of doing a transluminal technique or an antegrade technique. In a transluminal technique, again, you have an option of hepatogastrostomy or a colondocodostomy. If you're resorting to percutaneous technique, you have external drainage catheter initially, later you internalize it, and sometimes you have an internal external drain. Again, here you have an option of choosing a plastic or a metal stent. So once we decide to drain the biliary system, the questions are whether you need to do a percutaneous or versus an endoscopic drainage. So this is a meta-analysis, again, an 2015 meta-analysis, which included 3 randomized controlled trials. However, one of the trials was very old, 1987, other was 2002. What they found was there is no difference in therapeutic success. And if you can see, one of the randomized controlled trial compared a percutaneous metal stent versus endoscopic plastic stent, which comparison is not fair enough. Second meta-analysis showed there is no difference between the percutaneous and endoscopic approach, while a retrospective study showed that there was a high technical success in the percutaneous group. So you have different results with these meta-analysis. This is again a 2016 meta-analysis, and the reason why I have put it up is this involved hilar obstruction alone, while the earlier meta-analysis, some of those involved other lower and biliary obstruction as well. So these all patients were with hilar obstruction, and if you see the number of cases were around 546. And what was concluded in this, that PTBD is superior to endoscopic biliary drainage. The PTBD was associated with the higher rate of successful biliary drainage and lower rate of cholangitis. However, the endoscopic drainage has lower bleeding complications compared to PTBD. And PTBD was comparable to endoscopic biliary drainage in regard to overall adverse effects and 30-day mortality. So this study showed that PTBD was superior to endoscopic biliary drainage. So the other problem is whether to choose a plastic or a metal stent in patients who are unresectable. Mind you, we're talking of palliation here. So this is a meta-analysis, again, in 2013 meta-analysis, 830 patients. Here they found that the SEMS had a higher successful drainage, lower early complication, longer stent patency, and a survival advantage. So in this, they concluded that it is cost effective to insert a plastic stent if the patient's survival is expected to be less than 4 months. So this is again a meta-analysis in study in carcinoma gallbladder, SEMS versus plastic stent. You can see metal stent 28 patient, plastic stent 31, published in Digestive Endoscopy. So what they showed here was there is no significant difference for clinical success, early adverse events, and cholangitis. So this study is particularly done only in patients with CAGP, and it is rare to find these studies. Median patency and survival were not statistically different. However, the overall cost was higher in metal stent than in plastic stent. So what they concluded was you should be choosing a plastic stent if you want to make things cost effective. Then the issue is whether you need to do a bilateral or a unilateral drainage. Again, a meta-analysis, slightly 2013 meta-analysis, where they used metal stents. These are 13 studies where they used bilateral. Unilateral was done in 8 studies. You can see the number of patients, 575 in unilateral and 340 in bilateral. So what they concluded was insection was less successful with bilateral stents, greater decrease in the bilirubin, less frequent early, late, and overall complications. However, there was no difference in cholangitis or 30-day mortality. Plastic stenting, whether you do a unilateral or a bilateral, there was no difference in the two. So this study is a randomized controlled trial, bilateral versus unilateral. The only randomized control we have for bilateral versus unilateral, published in GI Endoscopy 2017, which concluded that there was a similar technical success rate. However, the bilateral led to fewer reinterventions and more durable stent patency. Again, what is uniformly accepted is once you have a hilar block, you intend to use air rather than injecting contrast. So this is just to prevent the occurrence of infectious complication post-procedure. Then once you choose to place metal stent, the question is side-by-side stent versus stent in stent. So what these studies show is there is primarily not much of a difference if you see the success of drainage, early complications, or late complication. It has been shown in the Korean studies. There was not much difference. However, in another study, it was shown that the complication rate was higher in stent side by side, and the cumulative patency was longer in side by side stent placement. So recently we have been using RFA in malignant biliary stricture, and this is a meta-analysis of 9 studies, 500 patients, which showed that using RFA lead to increased stent patency and probably improve in survival. So this is only one meta-analysis which is available. However, there is a high risk of abdominal pain. There is no difference in cholangitis, cholecystitis, pancreatitis, and hemophilia. So this is an algorithm. If you see the predicted survival is longer than 3 months, then you choose a metal stent. You see the type of the stricture. If it's bismuth 2 and you can drain more than 50% of the liver with one stent, choose one stent that is unilateral, and it's primarily an endoscopic approach. If you can't do that with a single stent, use bilateral or multi-segmental technique. Endoscopic approach here may be favored. However, if you have a bismuth type 3 or 4, you need to drain more than 50% of the liver. If you are able to do with a single stent, choose that. Percutaneous approach may be favored here. And if you can't do with a single more than 50%, then you use bilateral stents. So to summarize, P procedure MRCP is needed. Percutaneous approach may be preferred in bismuth type 3-4. Metal may be preferred if expected survival is more than 3 months. More than 50% of the liver needs to be drained. And RFA, in addition to stenting, may improve survival.
Okay. Thank you very much, Dr. Praveen, for taking us through the endoscopic palliation. So if you can stop sharing the screen. I think the questions and the concerns about endoscopic palliation, I'm sure there'll be a lot. We can take them up as we get into the question segment. And that will be after we have covered the next portions. So now we have talked about the endoscopic palliation. As Dr. Praveer has pointed out, there are many situations in which there may be percutaneous palliation. And I think percutaneous palliation in gallbladder cancer continues to be a modality used for treating a large number of patients. So I'll request Professor Baijal to take us through the basics of percutaneous palliation for biliary tract obstruction. Professor Baijal, please.
Yeah, thank you. So I think Praveer has covered a lot, and now there's not, it just depends on whether you're going antegrade or retrograde. But effectively, just for even at the risk of repeating, the most important thing is that the patients which we would do interventions would be ones in which you hope to achieve that 50% or greater drainage, if not all of it, of course. And the other issue would be patients who have their coagulation within acceptable limits and a platelet count of at least more than 50,000, though ideally we would want it at 1 lakh. And ascites is something which scares us percutaneously, but we have on occasion many times drained the ascites prior to doing the intervention. But we need to understand that patients with large ascites and very moribund and poor performance score would be patients who would have the least positive outcomes. When it comes to bilateral interventions, obviously, like Praveer said, the higher grades of obstruction mandate a bilateral approach to get your adequate liver drained. Inadvertently, if there are contaminations, they have to be then drained on both sides, and sometimes a non-dominant or an atrophic segment has been inadvertently intervened with, and you need to really then drain the other side. Bilateral brachytherapy or any form of intraductal therapy strategies, if they are being used, would require access to both sides. Next, please. Vivek, could you move the slide? Yeah, thanks.
This one?
Yeah, that's right. So as you can see here, that this is a patient in whom there are some abscesses on the left side, and there is a hilar block. You can see both sides are extensively isolated, but this patient needs biliary drainage for the right side because that's where the large liver volume is, and the left side needs to be drained because the abscesses are on that side. So you need to really land up doing a full hilar reconstruction. Next. Next, please.
Are you getting the slide?
No,
We don't see it.
the slide is not moving. Do you want me to take the screen?
We can do that. I think there's a network again. Dr. Saraswati is.
Probably
Yeah.
signal problem. Just give me a minute. I'll
Let him
adjust
share
that.
it. And he can share slides. Dr. Bajal can share slides.
Shall I?
Yes, sir, you do that. Sir.
Okay.
Can you see that now, Bajal, or this is still not visible?
Just a minute. No, it's not.
No, so maybe you could use your thing and continue with this, because I can get the voice.
Yeah, we can see now. We can see
Yes.
now.
Okay, right.
Brilliant.
So this is again a patient in whom you can see that the right side is extensively isolated and all four systems were separate, and the left volume was virtually negligible. So here you've got to do multi-system involvement to really get the bile draining. So we had to do all four segments of the right side. We left the left alone, but all four systems of the right were drained to achieve good palliation for jaundice, and this patient went on for further targeted therapies with chemoradiation, and I know that the survival turned out to be nearly 16 months. Next slide, please. So I think we can skip this because Praveer has already covered it. Just interestingly to say, if you can go to the next slide, that for the percutaneous outcomes, the analysis revealed a slightly different outcome, in which if bilateral accesses are made and two parallel stents are placed from either side going downwards, that yielded the best results as compared to if you were to do a T configuration inside the liver. Next slide, please. And just to show you, that's an access from both sides and a reconstruction from both sides. Next, please. Because of the entire structure that we've been through so far, from surgery and palliation, wanted to share a success story, though it's not cured, like Dr. Anil had mentioned earlier. 2015 gallbladder cancer operated, 2016 biliary obstruction, endoscopic intervention happened in October of 16, and a single system was drained. 3 months later, the patient was back with jaundice and required extensive drainage of the right-sided isolated systems. A full reconstruction was done. An intraductal RF was also done to try and improve our outcomes of patency and to improve better quality of life. Next slide. The patient went to chemoradiation once the bilirubin fell down and came to less than 5. Next slide, please. The patient lived for nearly 2 years, came back with biliary obstruction on the right side. We re-intervened, put 3 more biliary metallic stents inside those 3 stents. And the patient went again with palliation, went back. But this time the results weren't that great. Came back again after about 5 months. Next slide, please. In which case then we put internal, external catheters. And again, she lived for another 6 months after this, when she finally succumbed to her disease. But we were able to pull her through from 2015 from surgery. So virtually all modalities were involved, that the surgeon, the endoscopist, percutaneous, oncology, radiotherapist. Next slide, please. Introductal therapies, like we alluded to, this brief experience at SGPGI that we had when we were there, we had nearly 85 patients, and we found that the stent patency rates and the survivals were better in the stent plus ILBT group as compared to the ones in whom only stents were deployed, where the survival was only 4 months versus 7 in the combined group. Next, please. If you look at the data worldwide analysis, you would also find that there is definitely a survival tilt towards the patients who had RFA and a stent as compared to a stent alone. Next slide, and that definitely correlates very well with the stent patency. And as you can see, all the plotting is on the side favoring the RFA plus stent as far as the stent patency is concerned. So that definitely means that keeping a stent patency definitely does translate to a slightly increased and improved survival. Next slide, please. When it comes to photodynamic therapy and comparisons with RF, not very much to speak about. I think they're virtually equal, and I think RFA is far easier, cheaper, and easily available. Next slide. And if you look at RFA plus SEMS, like I said, versus SEMS alone, we found conflicting data on review of literature, but there is experience going both ways. Some people saying that there may be no difference, but there are equally strong experiences saying that no, a combined definitely makes more sense. Next slide, please. And like you had asked me to mention, when we really run into trouble and you really just can't find your way down, do we have alternative approaches? Yes, we do. Try to take these drains to the stomach, and we drain them extra anatomically towards the stomach and complete an internal drainage. But that's what palliation is, to get the patient internally drained and tube free. Next, please. So these are just the last few slides. So looking at some recommendations that came from the European Society of Endoscopy, in which they said, like Praveer had mentioned, that the higher levels of block are probably best tackled by percutaneous as compared to endoscopic routes. And definitely the endoscopic routes for complex drainages need to be done at high volume centers. Next slide. And this should be done obviously based on what is the local expertise, and like Praveer had mentioned, backup available. And we need to have endoscopists and multidisciplinary teams to really make up the strategy of intervention. Next, please.
Yeah,
and
this
therefore,
is the next.
Yeah, next, please. So, and next, and which is actually my concluding slide, that we really, all of us have to really get on the job to really fight this terrible disease to give the best outcomes to patients. Thank you.
Thank you very much, Dr. Bajal, for this excellent overview of percutaneous and what all can be done by the percutaneous interventions. So now we come to the last segment of our presentation, that when in an inoperable patient, unresectable patient, we have done palliation of the major symptomatic issues like biliary tract obstruction. What is the further benefit? Well, chemotherapy, we found that neoadjuvant and even adjuvant, there is not much role. It would be good to get an insight from Professor Atul Sharma about what palliative chemotherapy can achieve in gallbladder cancer. So, Dr. Atul?
All right. Thank you once again. So the three important questions would like to answer in 5 minutes. Number one, whether the chemotherapy improves survival in unresectable cases or not. If yes, what kind of the chemotherapy? And the third and the fourth most important thing, that as you all know, the large chunk of these patients unfortunately present with the poor performance status and the high bilirubin and so on. So whether there is any role of any kind of the systemic anti-cancer treatment in this setting. So we'll go one by one. So first, this is the problem we can ask. So this is what the study we published about 10 years ago to answer whether chemotherapy improves the survival in gallbladder cancer, which are not resectable. So we compared, we did a 3-arm study, best supportive care, combination of 5-FU folinic acid, which used with the prevalent practice that time, and the new protocol, we called it the modified gemcitabine and oxaliplatin. Would like to highlight that the gemcitabine and platinum are two compounds which are very commonly used in pancreatic cancer, and we also borrowed it from there. Next one. So by this study, we proved that the chemotherapy improves the survival, overall survival, doubling of the compared to the 5-FU and folinic acid or best supportive care. And also we get about 24 to 25% of the responses because of the chemotherapy. Next one. So these are the survival cards, so we can move on to next one. So this was the second publication during the same time that from the UK's ABC group, which they compared the single agent gemcitabine with the gemcitabine and cisplatin compound, which is one of the standard practice. Next one. In this study, they showed that the combination of the two drug is superior to one drug, and there's improvement in the overall survival. Next. The second thing is that whether the two platinum compound work the same way or one is superior, inferior to another one. So we did this equivalent study and published last year in the European Journal of Cancer. This was a little larger study, 260 patients. Next. So this was the equivalent study comparing the two arms, 130 in each group, and 243 were analyzable, gemcitabine oxaliplatin versus gemcitabine cisplatin. And we showed here that the thing is that the gemcitabine cisplatin is given for 8 cycles, that makes about 24 weeks, and our protocol finishes in 18 weeks. This study failed to show that the gemcis is equivalent to gemox, but the toxicity profile is different. So in practice, one may say that these both are almost equivalent. Next one. Next one. So next, this is another gemcitabine oxaliplatin comparing GEMCAP non-inferiority trial, and the authors proved that this is non-inferiority. So the bottom line is that gemcitabine platinum or gemcitabine or one of the 5-FU derivative. Next one, please. Next, we can move on to the next. So number of these patients, I said they present with a poor performance status. So whether there is a role for any systemic treatment, we are trying to answer this. This is ongoing. Part of this is complete. So this again is a 3-arm study comparing erlotinib and best supportive care. Best supportive care is common to all. So one arm get the erlotinib, which is a small tyrosine kinase inhibitor used also in the pancreatic and lung cancer. Second is oral 5-FU, capecitabine. And third is best supportive care alone. Next, this is 105 patient involved study, and we can move on to this study. Also tried to incorporate the quality of life, EORTC quality of life prospectively. Next. So this is the study design. So we have already discussed erlotinib in the dose of 150 milligram. So next one, please. So this study showed that the median overall survival in best supportive care is just close to 2 months, and there is a doubling of the median overall survival by using the small molecule or tyrosine kinase inhibitor erlotinib. So this study suggests that for the chunk of the patient who present with the poor performance status, where actually we are expecting a median overall survival about 2 months or less than that, you can at least double the median overall survival. Next. So this also showed the improvement in the clinical benefit rate at 6 to 8 weeks. Next. So coming about the targeted agents, unfortunately, none of the targeted agents have been shown to improve survival in gallbladder cancer. Next. There is a buzzword about, next one, please. So there is next one. There's buzzword about the immuno-oncology or PD-L1 inhibitors, which is supposed to be seen in about 5% of the gallbladder cancer. That is the higher expression of microsatellite instability or this thing. So these are the targets for the immuno-oncology drug, which is seen in about 10% of the cholangiocarcinoma. And the early experience suggests that they may have some durable response with the use of immuno-oncology drug. And this is one of the major area of investigation in the gallbladder cancer. Next, I think this is the last study. So this is a summary slide that probably this is common in India. We need to answer and so on. Thank you. I would like to stop here, and any other questions from the audience or this thing, we'll be happy to take those questions.
Well, thank you very much. I think with this, we come to the end of the formal presentations in the panel discussion, and I'll stop sharing our slides. And I'm sure there have been questions, which I'll request if Dr. Govind would have screened some of them, and he can, we are 10 minutes past 1, slightly over time, but maybe there is 10 minutes or so we can devote to addressing audience questions. So Govind, please set the ball rolling.
Thank you so very much. I did such a wonderful overview on carcinoma gallbladder, and all very important points were discussed. The certain questions from our viewers, starting with 2 questions on surgery to Dr. Anil Agrawal. This is a question from Dr. Resu Khandelwal, Dr. Jayanti, and Naveen. And the questions are, who are the patients who you will not operate? And this is the first question.
I read some of the questions, so can I take those 2-3 questions together?
Yes. Please do.
Yeah, I think one was that CA gallbladder with hepatic infiltration, are they resectable? Yes, they are. And the magnitude of resection will depend on the extent of involvement, whether you want to do a segment 4B5 or extended right hepatectomy. And yes, biliary imaging is required after preoperative biliary drainage before taking up for surgery. And one question was that extent of lymph node resection to be done. So in that, I'll just show this. Is my screen being shared?
Yes, it is.
Yeah, so you can see that around the hepatoduodenal ligament, along the hepatic artery to the right of the celiac, because to the left of the celiac will be metastatic. So I think these are the group of lymph nodes and retropancreatic. So these are all the group of lymph nodes, I just tried to put 2-3 slides together to answer the other two questions. And one question was about the T3 survival. And I think you can see that will depend on, though T3, a lot of them are actually lymph node positive. But you can see that when we talk about survival, because I think we talk about months to years. So I think a lot of time we shouldn't be fussed about 5-year survival, but even 5-year survival, you can see is to the tune of about 20%. So which is a pretty reasonable survival. And I'll quickly go through. And also similarly, if you see gallbladder cancer with jaundice, in this you have median survival was, though worse in patients with bile duct involvement, but 23% and 1.5 year versus 54% and 15.4 years. And 12 patients survived out of these 70 odd patients, 73, beyond 5 years, which is pretty reasonable result. And also just the thing is that somebody asked that T3, I mean the adjacent viscera involvement, as you can see that when T3 is one other adjacent organ or structure involved, liver infiltration or one other structure, and T4 tumor invades the main portal vein or hepatic artery or invades 2 or more extrahepatic organ or structures. Now coming to the question about the unresectable and borderline resectable, actually, the borderline resectable is less defined in this, in gallbladder cancer, less than what is talked about pancreatic. And Dr. Atul Sharma also mentioned about unresectable. Actually, it is very difficult to say what was actually unresectable, which was made resectable. Because like what I would say is that because depending on your philosophy, like we tend to take the adjacent visceral resection, even 2 or more. So a tumor which, let's say fundic tumor, which is involving the duodenum or the stomach and the colon, that would be a resectable tumor if you are ready to resect the adjacent organ. I think in the borderline resectable, most of the tumors are which are infiltrating towards the hepatoduodenal ligament side or into the pancreatic infiltration, and where you think that probably you may not be able to get a reasonable clearance. Either you'll have to do an HPD, which may be more risky from that patient point of view.
Right.
So I think the definition keeps changing. And madam, this question, I think what is unresectable, I think I would divide that into vascular infiltration and to the extent that you are able to go. But like technically some patient may be resectable, but may not be suitable for doing a hepatopancreatoduodenectomy. So those would be unresectable from a practical standpoint. And vascular involvement, what we also presented and not yet published, hepatic artery alone, right? Hepatic artery alone is not a contraindication, and you can still do a parenchyma preserving dissection. If artery and right portal vein is involved, then you need to do an extended right hepatectomy. And though the Japanese literature talks about main hepatic and main portal vein involvement, also some can be resected, but we would take it as a contraindication for resection. And only in that group, if portal vein main is involved alone and not the artery, we can do a main to left anastomosis and do resect those. So I think that in a nutshell is some of the questions that I have.
Let me ask other question, which is that again at the cost of repetition, and this is a very important question. I think there are a lot of in mind a lot of people, and this question is asked by Naveen from Jodhpur. That in a patient with carcinoma gallbladder, which lobe do you want to drain? This is for Dr. Praveer to, although you covered this part, but this again very important question. You want to drain left lobe or right lobe? You do put 2 stents, 1 stent. Just at the cost of repetition, I want to ask you this question.
So do I answer? Praveer, okay.
Yeah, so basically what you're targeting is greater than 50% of the liver volume if that can be drained. So if you have, you should be doing, as I mentioned, an MRCP with the MRI just to see that there is no atrophic lobe as such. And then I don't think there are studies comparing right versus left, but if you even placement of a single stent, if the patient is not having cholangitis, you can go ahead and do that.
I mean, any preference, right or left? If you have a both, you can put your wire any side. You can do any lobe.
So usually there are left lobe is usually preferred. If you see now we have some experience with US guided hepatogastroscopy for patients with hilar blocks in CAGB, where we do US guided hepatogastroscopy. Obviously, the left lobe is easy; the volume is more there. And even if you get a PTBD done, the radiologist also prefers segment 3. Is that right, Dr. Bajal?
So what I would say, we've got to remember that this is gallbladder cancer, and gallbladder cancer, when it goes towards the liver, Anil will also agree, probably goes more towards the anterior sectors more rapidly. And invariably in advanced GBC, you would find that the right posterior 6 and 7 are usually intact. Right anterior 5 and 8 have multiple system involvement. If it goes towards the left side, which it does later, I agree what Praveer says, that you would get the left anatomy usually intact. And if it does move that way, it's segment 4 that gets isolated. So if you're going to look at the volumes, it's totally based on the volume. If you've got all the volume on the left, then just do left and that's it. But if you don't, then I think the best probability, needs validation on the MR, would be a left lateral and a right posterior, because that's where gallbladder goes the latest.
Can I make a surgical request in this? Hello?
Yes, please. Yes, please. Yes, please.
Yeah, because actually, you know, when you are talking about palliative, that's fine. But
I'm talking about palliation.
Yeah, that's right. Because when you talk about a surgically resectable patient, because you would certainly want a non-cholestatic future remnant liver, because the functional liver tissue would be more in that. And so the chance of liver failure would be less. And by that analogy, and because almost always you need an either extended resection on the right side. So it is better to target the future remnant liver, that is the left side. So that is what we always say. And we have had instances where the patient has been sent, and probably with the ease of it, it has been drained on the right side, and which we may have to wait a little longer or the bilirubin to normalize. So we would request to put on the left side. Having said that, probably this is more true when there is a hilar separation. When there is a hilar continuity is maintained and it's a good drainage, possibly it may have an equivalent results, because I think then you would expect the entire liver to become non-cholestatic almost in one go. So I think those would be some comments. And I think my request again for the intervention radiologist as well as for the gastroenterologist is that we must keep it in mind that some percentage varying from surgeon to surgeon may be resectable, and do not take it as that it is unresectable and what we are doing is only palliation. So that is just a request. Yeah.
We have Dr. Saraswati have some question.
Yeah. These questions, Dr. Bajal, I think the one question from Dr. Rakesh in Lucknow is the role of preoperative CT volumetry. We have been talking of CT volumes and liver volumes to be drained and to be left, cholestatic or otherwise. So do you resort to formal preoperative CT volumetry as a routine, or that's not necessary?
So the CT volumetry is being done only for those patients who are deemed resectable but need hypertrophy of the FLR, and hence to really get an idea of how much is really required and how much short is that patient for a satisfactory liver volume in the future liver remnant, is when CT volumetry would be done. And like Dr. Anil mentioned, absolutely, the FLR needs to be drained when we are targeting a biliary drainage first, and then move ahead to portal vein embolization strategy.
And here, can I just do a technical little correction, which earlier we discussed, that this is not what is called a borderline resectable, because portal vein embolization is usually trying to reduce the risk of liver failure. So these would not by definition come into the category of borderline resectable tumors, because those are only augmenting the functional residual liver volume.
Right,
to
but they
try
would
and
be
reduce the
borderline inoperable cases, right? If a patient doesn't have enough FLR, then you'd be inoperable. You wouldn't really
I
want to
don't think
operate
we
on
would
them.
use the term inoperable to them, because inoperable at that stage, but probably it will need an augmentation
That's
before.
right.
I mean, I don't know. I
At the
don't know
point
whether
in time,
it's
you have to categorize and decide the strategy. You're
right.
right that if after successful embolization and hypertrophy, you become operable.
Right.
So, I mean, that is the outcome. But when you start, you would consider him inoperable because the FLR is small, and then you would embolize to get the hypertrophy and proceed with the intervention. So while you're there, I think, Dr. Bejal, the other question was which subset of patients you think are ideal for portal vein embolization? So this is Dr. Anoop from Bengaluru who wants to know.
So, like I said, I do think we have a choice. We have to get that patient onto Dr. Anil Agarwal's table if he's willing to operate. So we can't be choosers, but we've got to understand that unfortunately there are some indicators which would tell us that we would not do wonderfully well in every patient. And those were those 5 that I had mentioned about advanced age, a very high bilirubin when it was when the patient presented, and if the FLR is very low and you're looking at a much higher volume and previous chemotherapy levels, along with diabetics and cirrhotics.
Can I have last 2 questions because in the interest of time? The question is again, I think it's a very important question. This question from Dr. Manas from Delhi, that after patient has come, looks like resectable, and you have put a drain, either endoscopic or percutaneous, it takes about 3 to 4 weeks time before it takes for surgery. So do you repeat imaging in the interval period or after the interval period before you take him or her to surgical table?
I think I answered that. It is absolutely, you will re-image that. And because as we talked about that in the interim, the disease may progress. And in fact, at times when there's advanced cases, probably a PET I would rather do at that stage rather than earlier. Because a patient who's needing an extended right hepatectomy, and what our approach would be a selective use of PET scan. And probably in some of these patients, you want to be sure that if you are going to do a more aggressive surgery, that you have other things kind of sorted out.
And one other question which brings again to the point that treating carcinoma GB is always a multidisciplinary. All those patients who are operated, even for tumor resected completely, would you send them to medical oncologist for chemotherapy?
Yes, we would send them. And I think, unfortunately, we have not been able to liaise as much as we would want to with Dr. Atul. I mean, we have our local, our oncologists who help us out. But I think we would, and I think all lymph node positive patients would definitely go. All advanced stage T tumors, which have reached up to the surface and going beyond, will go for this thing. What is a debatable or doubtful area is when we talk about incidental gallbladder cancer, which have had bile spillage and other kind of risk factors. So those are the categories we would definitely want to send to the medical oncologist. And in some of them, I think it is kind of a gray area, but I think these are definitely the patients which you would want to. And I don't know if you had time, maybe after that, XGC was also one question, which I think might be a good idea to take. Yeah.
Dr. Atul, you want to make some comment on that?
Just would like to add, other than what Dr. Anil has said, our protocol is anybody who has the T2 onwards disease, and of course, all without saying goes all lymph node positive, margin positive, they go for the chemoradiation or chemotherapy. But beyond that, anybody who is more than T2 onwards, we take them for the chemotherapy if they are referred to us.
So it simply means that a patient with carcinoma gallbladder will have to touch upon almost everyone. And this requires truly a multidisciplinary approach, more coordination amongst us, gastroenterologists, surgeons, oncologists, interventional radiologists. And again, I think we can, unless we do that, our treatment, the kind of treatment we provide to patient with carcinoma GB is our expert. He comes to gastroenterologist, we do our bit of it. They go to surgeon, they do their bit of it. And if they go to oncologist, they do their bit of it. But I think we need to move on from here and then, try and connect with many other specialists in treating these patients. And my last question is, after resection, No, leave that question. Leave that question. Who are the patient who say we do nothing? Send them home. Do we have such patient? Because a lot of patients will come to us and say that you do what? But are there some patient where we can say we do nothing except for symptomatic care?
Is the question to me?
Anyone, but this is again multidisciplinary question. So anyone.
It may be
When do we say
different for
do
different
nothing?
people.
Yeah, that's true. So what, from our perspective, anybody who is on stretcher, probably bilirubin, probably we had find that we cannot drain it. So our cutoff is close to 4. So anybody who has ECOG stage 0, 1, 2, and possibly now 3, and bilirubin equal or less than 4, we would like to give some form of the anti-cancer treatment. ECOG 4, that is absolutely those who are the stretcher or the bed bound, or where the bilirubin, despite the efforts of the gastroenterology or endoscopists or interventional radiologists, is not draining properly or this thing. These are the patients where at least we do not intervene.
With this, I have permission to close, Dr. Saraswat, or do we have any last?
No, I think I'd just like to thank the panel for their hard work and for having put together a very educative and informative data for in such a short time. We did run a slightly over time, and still many areas remain. It just goes to show the complexity and the dimensions. So I just like to personally thank the panelists for their effort.
So, yeah, Dr. Agrawal, yes, please.
Yeah, just the last comment is that I think the time has come to move from nihilism to realism. And I think we have to realize that, in fact, when you talk about percentages, we don't talk about not resecting a periampullary tumor, despite, let's say, CA head pancreas having a 15% 5-year survival. But when it comes to gallbladder cancer, we have a lot of nihilism among not only, all categories of people. So I think I just thought that looking at the world literature and some of the experience from the centers in our country, I think there is a time to give up nihilism and move toward realism. And realism is not optimism, it is realism. Thank you.
That's very well said. I think that's true. That I think I learned a lot that patient with carcinoma gallbladder, we have a lot of options available. It may not be always cured, but again, we can increase survival by. Certainly, it requires a lot of money, requires a lot of support, hospital, and kind of infrastructure we have. But again, it's good to move on and make teams and provide these patients a multidisciplinary approach. So what we discussed today with this panel was that who are the patients who can be resected. Then if you can't resect, then how can make them resectable by two strategies, either by a neoadjuvant chemotherapy or by decreasing liver volume by portal vein embolization. Then those patients who cannot be operated, can you give adjuvant chemotherapy? And how do you palliate these patients? Again, palliation of multiple symptoms. And but we discussed only today jaundice palliation, which can be done by endoscopy or by percutaneous. Dr. Pravir showed a very nice chart of what all options available to us, and Dr. Vajal showed wonderful. Most difficult cases who could given life for almost 3 years by putting multiple segmented drainage. And lastly, if nothing can be done, then again palliative chemotherapy and targeted therapy. So overall, the ambit is too big, and surely 1.5 hours was certainly a short period of time. But all our panelists and the moderator had done a wonderful work. This is an important disease, is a difficult disease, but again we had discussed a little bit of it. And our whole aim of this masterclass was to draw a algorithm in mind of all of us, that when patient comes, what are options available and how do we go about it. With this, we close this session, and thank you personally to Dr. Saraswat, Dr. Agrawal, Dr. Bajal, Dr. Atul, and Dr. Pravi Rai for a wonderful work, and coming on Sunday afternoon, your family time, to the masterclass. Thank you so very much for coming to masterclass. We will have a next session. Thank you so very much. We'll have next sessions again on 13th of September, and the topic would be cholangiocarcinoma. Again, it's a multidisciplinary discussion. This will be moderated by Dr. Sandeep Laktakia, and we will have a very esteemed panel of discussant on this topic. So we'll see you on 13th of September. And just to remind you that the abstract date for ISGCon has been extended till 15th September. Please do submit your abstracts and your papers for Young Investigator and plenary sessions by 15th of September. Thank you so very much again. Thank you, Alka. Thank you, Mahinder, for supporting this. And thank you, Dineshji, for a wonderful technical support. Have a nice Sunday and see you on 13th September. Bye.
Okay. Thank you. Bye-bye all.
Thank you.